Hello, everyone, and welcome to this I3h seminar. It's a special pleasure for me to introduce our speakers of today, Anne-Lorraine Clause. It's a special pleasure because, first of all, I was primarily a nephrologist. This is how I start my medical career. And as you know, now I'm in charge with Matthias and Hilde of I3h. And in a way, I hope that Anne-Lorraine, and I think that Anne-Lorraine is also following this path, starting by studying patients and then realizing how important it is to also consider other aspects beyond the classical medical aspect, including economic aspect. I'm also very pleased to know that the head of the Department of the Nephrology Hospital where Anne-Lorraine is working is with us today. Bonjour Alain. J'imagine he's listening to us, but he cannot talk probably. Yeah. Okay. So just to introduce Anne-Lorraine, as you realize, she's a clinical nephrologist, meaning that she's taking care of patients with renal insufficiency, and there might be different degree in renal function impairment. And she started training at Saint-Luc Hospital, and then she's now part of the nephrology department at the Erasmus Hospital, where she's especially in charge of home dialysis. But I understand, and I think that's quite important, that you are still interested and very active in working in general nephrology so that you don't lose really the focus of nephrology and renal diseases in general. Now, we met each other when you told me, you know, I'm working on different questions, how we could indeed improve home dialysis procedures, because the dialysis procedures are very heavy, both for the patients and for the social security. And you are thinking of new ways to indeed implement dialysis, not in hospitals, but at home. And there are many considerations around these home dialysis activities. And this is, I guess, what you will tell us today. I will not make my introduction longer. Simply, I would like to thank you for coming here this morning. I think that it's really a pleasure to welcome you. And again, thank you to Alain for introducing you to us. So the floor is yours, Anne-Lorraine.
Thank you for this nice introduction. So today the seminar will talk about how to link the cultures of care, and especially the way we are educating patients, the way we are providing information, and we are involving the patients in their own decisions, but also in the macroeconomic perspectives. So bridging the gap in pre-and renal disease education, I hope at the end of the seminar you will be convinced that there are still a lot of big opportunities for our society, but also for the healthcare systems and for the patients. So first of all, the summary of this presentation, of course, as we are not all nephrologists, I will present you the basic concepts of chronic kidney disease and kidney failure, but also the key findings in terms of macroeconomic of the dialysis landscape in Belgium, but also worldwide, and what are the economic burdens of the dialysis today, and how we could improve it, in fact, to release the pressure on already over pressure healthcare systems. And I will end by the importance of pre-end-stage kidney chronic disease education on both different aspects of patients' well-being, but also on all the survival benefit, the outcome for the patient, but also for the healthcare system and our society. And I will just have a few words on my research project, which is focused on the cultures of care, of how do they implement education and shared decision making when discussing about the different options when reaching kidney failure. So what is chronic kidney disease? As you may know, kidneys are vital organs. We have a lot of vital functions. The primary function is, of course, to purify the blood from the metabolic waste and to assure body homeostasis of all the chemicals and the pH. And when one of the function of the kidney, which is either metabolic waste purifications or blood pressure control is damaged, we talk about chronic kidney disease. So that chronic kidney disease refers to all conditions of the kidney that affecting the filtration capacity, the removal of waste, and all the hormonal functions of the kidneys. Okay, so if we have a patient, we have a filtration capacity of the kidney which is reduced and that lasts for more than 3 months, we talk about chronic kidney disease. And of course, this patient can present with abnormalities in the urine, such as albuminuria, hematuria, or pathologic features on imaging tests or on renal biopsy that are the proof of lesions. And so CKD landscape, you have to know that it's a huge problem of public health problem, because we presume that 1 in 10 adults exhibit biological or clinical symptoms of CKD. We are 10 around the audience, meaning that maybe one of us is reached by chronic kidney disease. So you have different stages according to the mass of nephrons, which has the units of filtering, the filtering units that are damaged, and more filtering units are damaged, more you can reach kidney failure stage. And at this stage, most people doesn't feel nothing, they are feeling well. They might have some abnormalities, proteinuria, increased proteinuria in their urines, but most of the patients we see in our clinical practice as nephrologists have already a stage 3 or a stage 4 chronic kidney disease with reduced filtration capacity up to 15 milliliters, 50%, and most often abnormalities in the urine. And even with the best management, some of patients might progress to kidney failure, and we have estimates that 10 million of patients worldwide are now reaching end-stage kidney disease. And so those patients, to keep alive, has to require dialysis or transplantations to be alive. And so you can see from the Lancet epidemiology study published now 10 years ago, the projections, projection of overall CKD and stage kidney disease, and you can see that in 2030, the rate of kidney failures patient is expected to double compared to 2010, with approximately 10 million of patients worldwide who are reaching kidney disease. And you see that this is highest rates of increasing kidney failure in the developing countries in Asia, but still in Europe we have an increase, expected increase of patients with suffer from kidney failure due to diabetic, hypertensive, but also obesity pandemic. Also, climate change, environmental pollutions are still playing a role in chronic kidney kidney failure. So we really need, as we see this world landscape, we really need to find some more cost affordable solutions to make dialysis more affordable for developing countries, but also to release pressure on the already overpressured healthcare system of Europe and the United States. And so when patients are reaching kidney failure, we have in fact 3 solutions. Of course, transplantations, kidney transplantations remain the best options that offer the best outcomes at lowest price. But we found the patients are not all eligible for transplantation, and even if they are, in fact, they have to wait until a suitable kidney is arriving for them. So that's more or less, they have to wait 2 years on the waiting list before receiving a suitable kidney. So they will go through the dialysis process for most of them. And if we look at the 2 main modality in dialysis process, you have hemodialysis, which use a blood pump to circulate the blood in an artificial kidney to purify the blood and to let it back clean in the body of the patients. You have that, you can do that hemodialysis within the setting of hospital, which is called in hospital or high care modality, or where you see that there is a lot of human resources. The patient have a lot of assistance and is not doing nothing by himself. But you have also low care satellite hemodialysis, where patients can do some manipulation himself and where there is less human resource, less nursing to carry on for them while being dialyzed. And you have the third possibility for hemodialysis, which is the home hemodialysis, which happens thanks to miniaturized dialysis generator. For instance, in one of our patients who is sitting in his sofa. And besides hemodialysis, you have also peritoneal dialysis, which is not using an artificial kidney, but well, the peritoneal membrane has a semi-permeable membrane with the remove of waste and the remove of excess of salt and water through this semi-permeable membrane, thanks to diffusion and convection principles. And you can use these systems of peritoneal dialysis either through manual exchanges or through the means of a cycler during the night, which allow you to be more flexing during the day because you wake up and you are not tethered to the machine anymore. So you can see that the hierarchy, the optimal pathway a patient should have when he's reaching kidney failure. I mean, you can see that before all, we have to consider for each patient the non-dialysis options, especially for the oldest one and the frailest one, for whom the dialysis has not proved any survival benefit while perturbing and while being associated with intrusive and reduced quality of life. So after the non-dialysis option has been excluded, you can see the patients in general can choose between hemodialysis and peritoneal dialysis. And in fact, there are few strict and very imperative contraindication or good indication for one or to another technique. So that's the choice of the final choice of the modality is mainly done by the patients, supporting by the healthcare professional who can tell him about which modality will best suit his needs, medical needs, and lifestyle preference. And you can see that patients afterwards, the optimal pathway, they can, when peritoneal dialysis is not working anymore, they can do at home hemodialysis, doing nocturnal long hours or assisted home hemodialysis, or they can do hybrid therapy, which combine hemodialysis and peritoneal dialysis. And despite the fact that Nowadays, in 2024, we have a declination and a multiple options to treat our patient. It has not translated into the adoptions of all those alternative kidney replacement therapy, because many of our patients are still landing by default in the in-center, very expensive structures to be treated by home hemodialysis. So if we look further about the macroeconomic landscape, you can see that overall large differences exist between the proportion of the different renal replacements modality between countries. Even if in Europe it's roughly the same, but you can see that there's a large, wide practice pattern variations in the different modality and the different dialysis modality we are providing. With overall, you can see high care or in-center hospital hemodialysis that still predominate in the landscape of dialysis, while a kidney transplantation is less available in some of countries, but it's well available in European countries. And if we look at the landscape of home-based treatment, you can see that it's also a wide variable proportion of patients who are treated by home dialysis, either peritoneal dialysis or hemodialysis in red, with in France and Belgium less than 10% of patients who are already today treated by home dialysis treatment, despite the likely benefits in terms of survival and economic for our society. And if we look the key findings closer, what happened in Belgium, I'm part of the committee. I'm standing at the committee of the Belgian nephrologist, so I'm aware a little bit about the numbers of patients. Every year we have more than 8,000 patients. We have to start renal replacement for the first time in Belgium, and this numbers is increasing annually. Maybe it has reached a little plateau after the COVID pandemic, but it has reached growing annually, and this increasing is especially highest in the patients who are older than 65 years old, meaning that the average age at dialysis starts is around 70. It's even 72 in 2023. So the oldest populations and the increased numbers of patients who require the dialysis with the aging population, of course, increase the cost of the dialysis over the overall healthcare expenditures. And you can see that dialysis and transplantations consume 5% of the overall healthcare expenditures, and this percentage is expected to increase if we are not doing anything to control these costs. The direct related costs are estimated about $500,000 by the health insurance I3h. But it's only the direct cost related to the technique. It's not the indirect cost of the hidden costs and the out-of-pocket costs. I will talk about that later. And so a patient who is reaching stage 5 CKD costs annually, yearly, 100,000 euro or dollars, owing primarily to the high cost associated with kidney replacement therapy. And in Belgium, you can see the proportion of the different modalities, with the blue in center hemodialysis, the pulse, it's the self-care dialysis or the low-care dialysis, and this is the home-based treatment. And you can see that in 2022, most of patients are still defaults in center dialysis, which is the most expensive way of treating all patients. And so that's the yearly cost of dialysis by health insurance, based only on the reimbursement they made. And of course, it has a lot of limitations because it includes not all the indirect costs, and the neither the global health associated costs, because all of dialysis patients are complex patients, comorbid patients with complex health needs, healthcare needs, and in fact, all these complex healthcare needs, such as hospitalization, emergency visits, laboratory testing, imaging testing, interventional radiology, and rehabilitations, hospitalization are not included in all the yearly costs of dialysis. So that it's really a little amount and not the big pictures of the cost of the dialysis patients. And that dialysis cost could be rethink as a matryoshka system. When you have a patient who is dialyzed, you have to pay the nurse and the doctors, you have to pay the dialysis consumable, you have to pay the dialysis machine, you have to pay all the tests and imagings and control tests, you have to pay the hospital facilities, all the drugs related to the dialysis, such as erythropoietin, irons, and also the transportations to the medical facilities and to the hospital. So that it's all related cost only due to dialysis. So that it's very more large than only the technique. And or does the reimbursements of the different modality happens in Belgium? In fact, in Belgium, we have a bundle system. So we try to, in fact, to englobe entails all these costs in one package price. I would call it like the package price, which is divided into a lump sum per sessions per day of dialysis and a medical fees. And you can see that the rates of medical fees and the lump sum for each modality in hospital, local, home, PD. And you can see the total amount of weekly treatments according to the numbers of sessions or the numbers of days the patients are dialyzed. And you can see that in hospital, HD is still the most expensive treatment, and it's most refunded reimbursed treatments in 2024.
If I may,
yeah.
I don't know, I'm not an expert at all, but I'm a bit surprised that the cost is not more different between the different. Because in a sense, you know, I guess you're going to say, look, we should all try and go home HD, but it's not as if this will change life completely for the budget.
Yeah. Yeah, I will talk about the real cost later on, because no, this was the proposed reimbursement fees by INAMI that was recently integrated in the care. Before that, PD was less reimbursed and home AG was less reimbursed, but the proposition for INAMI was to make some incentive to push people at home. Okay. So that they equalize a little bit the amount between the fees between the different modality, to make some incentive for the dialysis provider. But because before PD was even less reimbursed than it was no. So it just recently changed, and I participate to the real cost of each modality. And that's really interesting, you will see. And so you have the reimbursement and the real cost of the modalities. And of course, real cost and reimbursements are closely linked. If one is increasing, the cost of the consumable could also increase. So that normally they should reflect each other in a bidirectional way, but there are some differences you're gonna see. So you see that in the real costs of some dialysis modality, the home hemodialysis is not integrated in this graph because it was an old estimation which not integrate home hemodialysis at that time. It didn't even exist. And you can see that if we split the real cost for the hospital in human resource, consumable, equipments, so dialysis machine, etc., overhead, and other out-of-pockets and or charge, you can see that for hospital hemodialysis, the main component of cost is human resource. Okay, and consumable, in fact, are not so expensive anymore because there is a critical mass of patients, and the critical mass of patients and the big numbers of patients make that the consumables are cheaper, because you have a lot of industry and pharmaceutical industry. You can negotiate the price with them, and etc. etc. Whereas if you look at PD, human resources, of course, less expensive component of care, because most of the times PD, the patients do that himself, but you need, of course, nurses and doctors to follow and to provide educations to perform itself PD. But you see that the consumable, in fact, represent the most expensive component of the total costs. Okay, and if you can see, the real cost of PD, non-assisted PD, compared to the hospital HD is not so different, because of the price of this component, the consumable, because there is a monopolistic approach of the pharmaceutical that are pricing and that are marketing the consumable.
Lorraine, if I may ask about the equipment. Within the hospital, with one machine, you can offer dialysis to several patients, whereas satellite hemodialysis, you have one machine per patient.
Hospital HD and satellite HD is within the hospital or facility, just closer to the hospital. That meaning one machine can be used by 4 different patients.
What about home dialysis?
About home dialysis and PD, which is not represented here, is one machine per patient, of course. So, and all the consumables that are delivered at home are also very expensive. That's the fact is that you have a low and a few proportion of patients who are treated with this modality, so that there is a monopolistic approach by the pharmaceutical industry, and so it's really difficult to negotiate the price of this cost. But some countries have done it. They have put the government on it to regulate the price of this consumable that are delivered at home, and so it's reduced. It reduces, of course, a lot the PD price. It's I mean, PD bags is sugar, salt, and some iron. I mean, why is it so expensive? Because they only Baxters that provides PD bags, so you cannot discuss with them. Whereas the situation is really different from hemodialysis, where you have a lot of pharmaceutical industry that proposes services and consumable. So the situation is not monopolistic for that. So you have a march to decrease the consumable.
Concerning Michel's point about the fact that equipment is used more efficiently in the hospital than now equipment. These are these machines, but you don't have equipment in the last.
Equipment, normally it's there. Normally, for PD, you don't have a lot of equipment because it's consumable, but you can have the cycler machine, which is kind of a generator of dialysis. But that is expensive, but it's why it's not a lot. But there are some kind of equipments also for PD. And so if we are looking the hospital perspective for the different modalities, if you are looking about the current reimbursement and the charge of the sessions or the real cost for this whole across modality, I work with this consultancy company to work on the real cost for home dialysis. And so we split the cost at the I3h, the healthcare professional, equipment, etc. And we provide a kind of assumption of real costs, and reimbursement. And you can see that the profit margin from the hospital perspective, from the providers, is much more interesting in the in-center and self-care dialysis units compared to the peritoneal dialysis. But it's driven by the price of consumable. I would like to insist on that, because if you arrive to negotiate the price of consumable and you arrive to regulate this price, you can of course, provides PD for lower costs, and PD became the most affordable technique. And that's the meta-analysis done in 10 years ago that look about the ratio, which is really interesting, the ratio of PD costs and HD costs, the ratio HD to PD around the world. And you can see that according to the Human Development Index, PD costs less than HD, especially in developed countries. Okay, and there is a ratio of 25 to 50% in favor of PD. Let's make that, of course, it's not the same patients who start PD and HD, but it indicates that overall in developed country, if you regulate a little bit the price and you lower the import duty on the PD bags and consumable for home dialysis, in fact, PD is the most affordable treatments. And they adjust the system for comorbidity and demographic patients. And in fact, it was always in favor in PD in terms of cost and reimbursements. And that's a very interesting study from the Canadian. The Canadian have highest rate of home dialysis in the world. The 25 of the patients are treated by either PD or home HD. And in fact, what they have done, they did a retrospective study about the global healthcare cost, not only the dialysis related costs, but also they integrate the education costs, the hospitalization costs, the emergency visit costs, the imaging and the laboratory costs. They integrate all the home installation costs. Really a big pictures of what does a patient cost when he starts one or other modality, taking the global pictures of the patients and all the healthcare he needs. And in fact, they did that with a lot of data from the Ontario network reimbursement system, because they are all recording everything. And you can see, first of all, a patient who starts dialysis has the highest costs, okay? Because he is most often hospitalized, or he requires a lot of human resource, education, and imaging tests. But the costing, the startup cost is highest in the in-center HD, in hospital center. And you can see that the cumulative cost over a 5 years period of follow-up is still higher for in-center HD. And after 5 years of follow-up, the authors estimate that they could save 100,000 euro or dollars in Canada when starting a patient on PD or MHD on home HD compared to in-center HD, meaning that how and where the patient start dialysis has really a huge economic impact. Of course, there's a Canadian study which have a different system of reimbursement, maybe not a bundle, but I think per capita system. So it's quite a little bit different. And what is more interesting is they adjust the model of cost for demographics and for basic comorbidity, diabetes, hypertension, age, etc. Of course, it's not a perfect adjustment model because you are not integrating the frailty or the severity of the comorbidity, but it reminds that starting a patient on PD on home HD is probably the more cost-effectiveness strategy over time.
Anne-Lorraine, this is the Canadian study, but when you present the Belgian data, you didn't...
No, we didn't perform that.
You didn't look for home dialysis?
No, because we don't have any data. It's really pity for the Belgian registry. We don't have any data on home dialysis cost and registry. So that's
that's important, and I guess that you will discuss this when you come to your research project.
That's quite a little bit different because yeah, in Belgium we don't have the same reimbursement model, but it's what we have to know is which strategy we can discuss with our policy makers and our economists to reduce the cost of home dialysis, which is driven by the consumable and the delivery. No, and which is bring unfair competitivity with in-center hemodialysis. And so when we look at the cost of illness model framework overview, in fact, all these costing studies are really difficult to compare and are really difficult to interpret, okay? Because some studies are only looking at the ratio, cost ratio, PD, HD. Some studies are looking at the yearly cost of patients, and some studies are not including all the health system costs, including in the care of our dialysis patients, except the Ontario Canadian one. And so most of the costing studies focus on the cost of the simply basic techniques of dialysis and the service provision around, but not on all the health system costs, which include, as I say, hospitalization, imaging, etc. And also that the direct cost for the health system costs, but also they are not included, all these costing studies, the loss of productivity costs. And that's also the hidden costs, because the patients who can perform home dialysis can still work, can still be integrated in the, can still have a socio-professional rehabilitations, because the main advantage to perform dialysis at home is to be more flexible, okay, and to be more autonomous in the terms of the agenda schedules. So that all of this loss of productivity costs are not taken into account in all these costing studies, and that's really interesting, okay? And also you have to know that all the economic burden of dialysis is not only borne by the society and the healthcare insurance, but also by individual with the order of pocket costs, transportation to the hospital, for instance, family and carers, who sometimes have to diminish the work time to carry on for the patients, and the government. So that the global cost of dialysis is in fact extremely complex, okay? And the costing studies are not easy to interpret and to compare from one country to another country, because each costing study also integrates different parameters in the reimbursement and in the costs. And so also what is complex, and that's I told you with you, Professor Goldman, is that what is good for the patient and the society, more autonomy, more flexibility, lower the cost, is not always good for the hospitals in terms of profit margin. And that's the hypothesis I discussed also with Professor Eustache, is why there is still a low prevalence of home dialysis from the hospital perspective. First of all, we are thinking that in-center HD is probably overpaid as compared to its real cost on longer term, because, as you say, the machine is used several times, and as you said, there is a depreciation of the price, which is taken into account. So you don't have to pay a new facility every 5 years. And so this overpriced activity, okay, we know that, but it's covered the cost of underpriced activity, such as other health issues with the nephrology care, such as general nephrology consultations, the engagement of paramedical human resources, and also across the hospital, it compensates for departments that have a budget deficit, such as the geriatrician budget or the pediatrician budget. Because the problem is the sustainability of the economy of our hospital relies on the refunding of technical acts and not of education consultation. So that if you are not departments that provide a lot of technical acts, such as nephrology or radiology or biology, you have a department most of the time with a budget deficit. And so that dialysis departments, in fact, cover the department with budget deficit. Also, to start a home dialysis program, it's expensive because you don't reach the critical mass of patients. You cannot negotiate the consumable. You have to dedicate full-time dedicated human resources, even if they are not training full-time. So it costs a lot. It requires time and investment until you reach this critical mass to be beneficiary. And of course, there is insufficient incentive to develop peritoneal dialysis. As I said, the cost of glucosate in comparison to the reimbursement and the benefits margins is quite low as compared to the in-center HD, with no governmental regulation for PD back price market. For instance, China and Japan, they have a first PD policy, and they have regulated the PD market so that PD only costs the half of the price that it costs in our country. So that economic landscape, it's quite complex. It probably explains the way we are providing care, the way the hospitals are set up their programs and modality choice. But for me, it's not explaining all the modality selection choice process, and it's not explaining the wide variations in practice in terms of modality proportions and kidney transplantation rates, conservative management rates, and home dialysis rates. And so the role of culture of care for me and for my mentors is probably one of the key backgrounds, one of the key unresolved common grounds that also explain why there is still a low prevalence of alternative kidney replacement therapy. And so, what are the potential barriers when patients have to choose between home and center-based dialysis? But first, we have talked a lot about the lack of provider financial incentive and or penalties in our system of refunding. But secondly, the poor exposures of the healthcare professional to PD and home HD is really the root of the problems. It's probably that the main barriers to increase the adoption of home dialysis relies at the provider or at the nephrologist level, who is not confident enough with home dialysis prescriptions, which is not enthusiastic enough, and who can play a role of barrier or sometimes facilitators to home dialysis. The lack of patients' education and free choice due to absence of structured pre-dialysis education program and dedicated nurses who know well the technique, who are skilled in shared decision-making process, is of course related to the lack of enthusiasm and lack of expertise of the healthcare professional. And that's why I would like to focus on the second part of my seminars. However, the CASTER reports already in 2006, you can see that's quite a long time ago, in the guidelines recommendation and the counseling, advocate that every patient starting on dialysis should be informed timely, fully, and objectively about the different dialysis modality. Objectively meaning that we have to weigh pros and cons, taking into account the medical needs of the patients and his lifestyle preference and life goals of treatments. And it's conform to the law of patients' rights. And the patient's counseling could be included as a requirement for all pre-dialysis patients in the existing ambulatory care pathway for end-stage renal disease. And in fact, we just received reimbursements it will start in July to provide better kidney failure educations to all of our patients. So we hope that it will translate in a more qualitative and more qualitative pre- and stage kidney disease program, but I'm pretty sure it's not only about economic and financial incentive.
And already, if I may, because you skip the guidelines. Obviously, it's important to inform the patients, but not every patient can benefit from all modalities. And very often you have to, so it's nice to give the full information.
Most of the time,
patients, but part of the information should also be in your situation.
Yeah.
This is, the modality which seems to be the most appropriate.
Yeah.
This is the modality that we cannot.
In fact, for most of patients, there is no strict contraindication to choose either modalities or others. There are only one true contraindication to PD is to not have PD access or the integrity of parietal wall. And in fact, we could do better. And there is too much veto, and the level of preconceived prejudice or opinions or preconceived veto among nephrologists is the root of the problems. It's because a lot of nephrologists are not confident into the techniques and do not dare to propose the patient's PD, while in fact it's working. It's pretty working. I receive a lot of patients who were refused PD in another sentence and restored PD with a lot of success. So it's really the level of prejudice because of a lack of education, knowledge, expertise, and experience who probably put the veto for PD or home dialysis too high. So we need to harmonize a little bit the strict contraindications and the good indications, and there's no national consensus on it so far. So yeah, I think we have to be a little bit broader in the information we could give to the patients and not trying to guiding him. I think the patients know what he wants, you know what is good for him, and you know if you are providing good dialysis educations, he would know which modality will suit best his needs. That's my philosophy of care. But of course, we can guide or nudge the patient's decisions according to the pros and cons of each modality within its specific medical situations. But for most of the patients, I would say 80% of the patients, they can choose either HD or P.
My other comment would be, obviously, you have to inform the patient, but also the caregivers.
The caregivers,
because
of
the
course,
impact of
the
each,
family.
Yeah, and this is not indicated here.
No, yeah, that's not indicated here, that's right. But of course, we include always the family in the discussions because, of course, the heaviness of the treatments relies also on their shoulder. Of course, the family is always included in the pre-dialysis counseling, but it's true that's an old phrase, but it was to highlight that it was a very old, very old guidelines. So pre- and stage kidney disease education, why it is important? Because patients at stage 4 need, even at stage 5, need to take a lot of key decisions that will, in fact, determine the life course trajectory with end-stage kidney disease, either they are transplants, which dialysis modalities at home, at hospitals, in a low care facility, which access, and what are the contraindications, etc., etc. And in fact, we need to do this process of education before they are reaching the terminal stage of illness with cognitive impairments and emotional distress that are associated with the start of dialysis. And so that's really important not to wait too long before providing these educations for patients. So you can realize that the education process for all these patients is not a one-off meeting. It requires repetitions, a skill staff, who is devoted to patient educations, and patients' engagement and reinforcement. And that's applied to the model of shared decision making. When you have to discuss therapeutic options or life therapeutic goals, you have to objectively present the options, the pros and the cons of each options, but also try to change you from the expert, paternalistic expert, to a more listener and an educator. And that's what the shared decision model asks to the healthcare professional. It's to listen to the patient, their needs, the lifestyle preference, and the life goal preferences.
Lorraine, if I may, I'm very pleased to see transplant here because it was lacking on the previous slide. I think that when you inform the patients, of course you have to discuss transplantation.
Of course.
And coming back to family, you have also to discuss the possibility of living donors because of
living donors,
organ shortage. And I think this should be part of the full picture.
This is part of I totally agree. It's just that I focus more on the home dialysis, alternative dialysis modality of take. But of course, living transplantations, conservative care are all strategy to reduce the cost. Huh? Of course. Huh?
No, because you know, family member might say, okay, then I prefer to take the risk, which is rather low, to give a kidney to my husband, let's say, than to go for home dialysis or even peritoneal dialysis. So I think that it's important to include this.
To include the living kidney donations in
the equation.
Yeah, and it's why it has to be done early in the process. Maybe not too late, I would say.
Yeah,
not too early because it brings anxiety for nothing. But not too late because of the living transplantations and all these kinds of modalities of renal replacement therapy that requires a little bit more time to be set up. And so why is it important? Because shared decision making, you may know, the last 2 decades, there was a shifting paradigm of care. We moved from standardization of care to a more personalized, holistic approach of care. And of course, it has changed the landscape of a lot of medical fields, and it has revolutionized the medical practice. We moved to a more personal approach, integrates more the holistic approach, the social needs, the medical needs, the familial needs, the financial needs, etc. And it's true that shared decision-making process is the essence of this patient-centeredness approach. And we are not, us as physicians, we are not trained to provide shared decision-making discussions. We are not skilled, in fact. We are not training at medicine school to announce bad news or to discuss with the patients of all the options. We just are learning to give our advice as a paternalistic expert. And that's really, I think, something we can change from this medical schools to learn to our future doctors to be better at communicated options, treatments, and therapeutic goals. We are in a hurry, and that's, of course, it's a big constraint to take the time to discuss the patients and have an holistic approach. And patients also can also have some kind of reluctance to choose. Huh? What would you do, doctors, if you were in my place? And that's a question I have all the time, but I really try to give back the power to the patient. And it takes time because I'm really, I really want to tell my recursive opinion what would be the best for the patient, but I really try to not telling always the patient what I'm thinking the best is for him. But it's real, it's everyday life practice. Patients are fear, injured, may present with denial, anxiety, depressions, that diminish the empowerment capacity of the patient.
I think, if I look at the 2 slides that you have, one of them is the supply side. So you have a problem on the supply side, and the doctors are not trained to be able to communicate enough. But at the same time, you have on the demand side, the situation in which, as you just said right now, you have lots of patients who don't want to know.
We don't want to know. We don't want to take decisions.
You may want, I don't know how you deal with that kind of situations, but the fact that a lot of my friends sort of trust you guys 100%, I don't want to know anything about it, just say it.
But we need, as doctors, to give the clues to patients. At the level of health literacy they have. Yeah. It's really important to work in it because we were not trained to do that.
No, I agree with you, but at the same time, you have a second bullet, and this is part of the incentive issues that you have built in the new commercialization of hospitals. You guys don't have the time to talk.
Yeah.
You just don't have the time. I mean.
Yeah, we are always in a hurry, and it's really.
And as a patient, unless you have a doctor who's willing to take the time and to work extra hours, I mean, you feel that also. So I don't know how you deal with that in your recommendations, but it's a serious issue, I think. The fact that you do have a time constraint on the supply side. And in addition, you have this demand side, which is really weird in the sense that you have some patients who are keen to be able to discuss with you and to learn with you and to decide with you, and some others actually don't want to know anything about it.
Yeah, it's easier, and I think it's more paternalistic, but also easier and to decide for patients. But it's right that it's time repetitions, and I see that in my own practice. On many times I have to discuss with the patients to reassure them, to try to empower them. But in fact, it's just it takes time. I really agree, and we need to maybe also reimburse some basic care, such as discuss with the patients. And the problem is that all the healthcare system is based on the reimbursement of technical acts. And as long as we don't reimburse and we are not considering educations or discussing with the patients, what are you expecting from life at your age, for instance, as long as we are not considering that as a medical act, it will of course increase the productivity of the hospital and increase the costs. We need to integrate this basic care, discussing with the patient as a real medical act.
That's where your idea of cross subsidies, being more transparent, maybe one option, because then you can say, this is my full cost. That includes time. And so since I do have, because the numbers that you showed in terms of the return to the activity show that you do have margin to finance some of the activities. That may be one way which you can make recommendation so that you do get money for the time that you spend. Otherwise, you're not going to get money. You're not going to get the money.
With sort of return.
Can I play a bit devil's advocate?
He's very good at that.
You know, who can be against patient-centered care? Okay.
Who can be
against patient-centered care? On the other hand, some patients are completely unreasonable. They can be, they can see conspiracies. They can just say, and I understand that, my child is worth $1 billion, and so, let me become a lobbyist for the industry that says, you should reimburse much more, this kind of thing. So you see, with rare diseases, which costs are exploding. So then there are some indeed who don't want to know anything, and indeed at times, okay, it's one thing. Do I want to know if I have a disease which is, incurable? Quality of life will not improve. So it's very different, of course, if indeed you understand that by eating less, it will be much better and so on. But so I think at times this idea of let's go for patient-centered care and that's okay. It seems to me at times it's a bit superficial.
I wouldn't say superficial because I think we can translate it by little step in our clinical practice, maybe the whole perfect story of patient-centered care, but sometimes just integrate the patient with social workers, take time to discuss the treatment option and also non-dialysis options, transplantation. It's only patient-centered care approach. It's just like we have to move from, if you are a patient, you would like to be treated as a unique patient. I know it's really like maybe highly demanding for the care units, but I'm not thinking that it's not unfeasible in our clinical practice, but it's maybe not the whole pictures of patients and nurse approach with all the paramedical team and the shared decision-making process for everything. But for little interesting and very important steps that have a huge impact on the life course trajectory, I think we can improve on medicine.
No, I think yes. And then you said something which I think is a bit consistent with what I'm trying to say. You know, every patient wants to be treated as a unique person.
Yeah.
But public health is about equity.
Yeah.
And equity means that we should treat people in a somewhat fair way.
Yeah.
And so
the equity starts to propose all the various forms of renal replacement therapy to the most of our patients. I think we can do that even better.
Yes, but could you tell us what's happening in UK with NICE? Because some patients are just denied to benefit from dialysis. So you know, they say, okay, this patient is too old and the cost of dialysis is not worse.
I wouldn't like to be a doctor in the UK because I don't agree with the.
No, but just to answer to Matthias, because some people really consider cost benefit from a society perspective, which might not be consistent with the patient preference.
Yeah.
Except that in the list of things that you have identified, you have lots of things which are benefits to society, which are also benefits. I mean, you have both social and private benefits at the same time.
Mm-hmm.
If you can go to work, if you can, all those things actually need to be included in a proper way to be able to make a fair assessment of whether the return is worth it or not.
Yeah.
And unfortunately, I was Googling to look at how they do the cost-benefit analysis on this type of treatment. And most of the key variables, which are both private and social returns, benefits, are ignored. They're just brutally ignored.
I think maybe it's too complicated to assess, or because there's no code.
There are techniques to do that. It's just that somebody has to pay for it. I mean, the research agenda, the thing is that I think the research agenda in this field does not cover this sort of issue. So that would be one item that you have to consider.
Yeah, and so if we carry on pre- and stage kidney disease education, it could be important for the healthcare providers, so dialysis centers, but also the society, is that it enhances, of course, alternative kidney replacement therapies such as home, the preemptive transplant rates or transplant listing, or even the living kidney donations. If we're talking about this modality, of course, it will enhance the use of kidney donations. It enhances, of course, also the good vascular access at dialysis start. As you may know, starting dialysis with the catheters is associated with higher mortality rates. And most of importance is that providing good preparation and good education as soon as stage 4 may delay initiation of dialysis for several months. So it slows the end-stage kidney disease progression. So from health regulator perspective, deliver good educations to our patients, not only information on the different modalities, but also dietary counseling might be cost benefits. But from provider perspective, giving education in a more structured and more elaborate times, it's the time, human resource, skill, efforts, and coordination. So we really need some funding for that. And so you can see that's a nice study, an open label cohort design study, where the patients were divided to 2 cohorts. the NPA cohort who receive a multidisciplinary education programs with a lot of assessments and peer patient, etc., from stage 3B. And compared to the non-NPA cohort, you see that it's delayed the initiations of dialysis, so less patients were starting dialysis at the end of the follow-up, compared to the simple delivery of information about all the modalities. And the better preparation has also a benefit impact. After starting dialysis, you can see that the survival rate was even better for this group. And the influence of pre-dialysis educations, of course, has a lot of huge impact, maybe the strongest impact on home dialysis rates, because you can see in this very nice study, this is quite a long study, but from UCL, Tony Govart was a nurse and specialist nurse in home-based treatments. I follow him when I was a young nephrologist in training, and in fact, he studied his cohort of dialysis patients, newly started dialysis patients, and you can see when patients are providing through educations with video, dedicated nurse, etc., 50% of them are opting for self-care dialysis, either in hospital, but they are more autonomous and it costs less, or either home dialysis. And you can see, of course, younger they are, higher the chance to opt for a self-care dialysis modality is, but even after 7 years, 10% of the patients are still opting for a self-care dialysis modality, meaning that they want to keep on caring for themselves and to be involved in their treatments. And the same study has been done in the United States since 2010. They have launched a policy incentive to reimburse pre-dialysis educations, and you can see that at any point of dialysis, at start, after 3 months, or at any point after in the follow-up, in the 10 years follow-up, you can see that the cohorts who received kidney disease educations were more prompt to choose home dialysis compared to the non-MPA cohorts. KDO cohorts. But of course, the patients who not receive KDO service were more frail, sicker, and were also with poor health literacy, meaning that there maybe are confounding variables in the rates of usage of home dialysis. And that's the positive impact. I would say positive is not so positive when you are reaching end of life, but you see that in that study, when you integrate the conservative kidney care management for the frailest and the oldest one, the non-dialysis option, to say that, okay, survival benefits for you is not proof, it will not extend your life, and it will not increase your quality of life because you have to go to the hospital twice a week. But we can also propose you to be followed up every month on an outpatient clinic setting and to give you some medications to relieve the dialysis-related symptoms. That's the conservative kidney care management. And that's really a good option, a valid option that is validated for the frailest and the oldest one for whom dialysis has not shown any benefits. Okay, and so you see that if you are integrated the conservative kidney care management in new pre-dialysis education or pre-end-stage kidney disease education, you see that most of the oldest would opt for these options. Okay, which is a quite wise approach, I think. So the rationale of my project, and I will end by 3 or 4 slides with the rationale of my project, is that in fact,
just before you go to this, just coming back to our previous discussion, it means that those patients actually might agree with some UK type policy.
Yeah, but we propose both. We propose dialysis or
yes, but you know the criteria of the HTA in UK is mainly related to age.
And no, in fact, it's a false, it's a mistake because age is not, of course, more you are older, more frailer you can be, but the frailty is not directly associated with age. And the advantage of dialysis is not associated with age, but well, the non-advantage of dialysis is associated with frailty more than with age.
It's like the debate on mandatory retirement of a given age. It's a big debate in academia.
So that the rationale of the research project is, so we think that having a pre-dialysis education program is probably a mandatory prerequisite to enhance alternative renal replacements other than in-center, whole confounding, kidney transplantation, etc. But however, this condition is not sufficient on itself, and it seems that pre-dialysis program, I would not talk about pre-dialysis because they are not leading all to dialysis. I would rename that on pre-end-stage kidney disease or advanced kidney care program, are working only when they are the true reflections of the willingness to offer the right treatment for the right patients at the right times. And we were asking what were the cultural drivers at the clinician, at first level, that support the patient-centeredness approach when you are counseling for the different options when you are reaching kidney failure. And so, for me, what defined the culture of team, which is more or less a person-centered approach or center-centered approach, meaning that you have to run the unit, fill the beds, and be productive, etc., or more a person-centered approach, meaning that you are taking into considerations patient's preference into the way you're providing care, is defined by first attitudinal promoter of the nephrologist and nurses. So the behaviors, beliefs, and value you have. Of course, the way you are providing cares and the importance of integrated lifestyles preference and a patient-centered approach, but also all the practice patterns of pre-dialysis program. For instance, if you arrive in a unit, okay, and there's already very skilled nurses who talk with a lot of enthusiasm of home-based treatment, who is in charge of 30 patients, who are doing very well, you will be more engaged to propose this kind of solution for your patients, meaning that some clinical practice aspects that are already running in the units you are working may have an influence of you, meaning that your attitudes and the practice patterns of the units where you are working have both influence to each other in a bidirectional way. And so that will define the cultures of the team and the where you are putting shared decision-making process in pre-end-stage kidney disease educations. And we have published the last, since the beginning of this year, a qualitative study on the factors influencing renal replacement therapy modality choice from the nephrologist perspective, because a lot of studies focus on the barriers related at the patient's level, medical or psychosocial contraindication for home-based treatments, and the organizational or the financial barriers to promote home-based treatments. But very few, in contrast, very few focus on the nephrologist, the barriers at the level of the nephrologist, his attitudes, beliefs, and values that play a pivotal role in defining the cultures of the units. Okay, and so we postulate that there were unresolved barriers, intrinsic barriers that stand at the culture level of the team that probably drive the other extrinsic, well-established barriers that we all know, organizational, financial, and patient-related barriers. And in fact, we found that next to already identified singular issues, as I explained, more intrinsic factors impact uptake of home-based treatments. And those factors intertwine and relate both to the process-level topics and as to the attitude and cultures of the nephrologist and patient-centeredness within the team, meaning that the nephrologist can have a role of facilitators or a role of barriers, to increase the free modality choice and the alternative uptake of modalities. And in the thematic, in the terms of visional approach, you see that we depicted 4 themes: organizational issue, vision of care, trust and belief, and feeling of control. We, in fact, we point out complacency. What is complacency? Is the inertia related to some attitudes, because you don't want to change the state of affairs, because the things are running good. The hospital is happy, the direction is happy. And so we feel that there was some complacency in the way respondents in the semi-structured interview were responding. Because, for instance, most respondents have the feeling that they are doing well already their best to support the pre-dialysis trajectory as it is. However, they don't know what kind of information provision is it, what are the skills of the educational staff, and they didn't even attend 1 session of educations, thinking that maybe they have other very important tasks to rule and to fix than education of the patients. And also a lot of nephrologists admit that in fact hemodialysis units are running well. They have a lot of well-established and organized protocol compared to the home dialysis unit, or you start from scratch. You have to establish new protocol because you have a few number of patients and you have less of expertise. And some are thinking that they admit that they lack of incentive, not only financial incentive, but also incentive enthusiasm to change the well-established program, because it requires more time, effort, labor, and guts. And regarding the pre-dialysis, we pointed in that study that pre-dialysis education is overall poorly done, with a wide variation practice in terms of the way they are providing, who is providing, the location of providing this education, the numbers of stations, who is involved in these sessions, what are the education tools they use, etc. The inclusion of peer patients. So that they just show that there's a lack of consensus of how we could improve this education and how we could harmonize the information provision. Because of course, as a patient, you will take the decisions on the information provision you receive. And if the information provisions vary from one center to another centers, it changes maybe your modality selections. And that's a qualitative study that's really interesting because she interviewed patients and educational staff, and she summarized that there's some problems in the way we are delivering education and the way we are communicating with patients about the different options. And she highlighted that all the staff, irrespective of their role, need to be trained about all treatment options so that informal conversation with patients are not biased. So, no, not doing in-center HV because it's too heavy, or other things we sometimes give to the patients, and it's not really, it's based on our own experience, but it's not generalizable. The study argues for a more individual approach, which is more like counseling than education, and would demand, of course, a high level of skill. And that is my time of my research project. We have done the qualitative study, and we have defined the driver influencing dialysis modality choice from the nephrologist perspective. And now in the second study I'm currently doing, we are using a few methods, which is an analysis, semi-quantitative analysis, to explore the perspective, but also the expectations of the nephrologist on the way we are providing education and how we can improve it in our clinical practice. And we hope, based on this finding, we could start a national Delphi survey with only experts to define what are the intervention priorities or national guidance to focus on the education programs in order to improve access and equity to other forms of dialysis. Because a lot of centers are not offering all various forms of renal replacement therapy. And when they do so, they are variably successful in making them available. And it's to abolish a little bit the wide center variation practice in terms of access to all those forms of therapy. We need a consensus on how to provide better education. This is my expected research project benefit. I have said kidney failure is a typical model of high socio-economic burdens for which a holistic and a more sustainable approach is needed. New financial incentive I just received to promote educations in Belgium at least. And the finding, I hope, of this 3 sequential study could help us to identify the barriers, but also the levers for actions to improve education and awareness of the different options among patients. Voilà. So that's here my conclusions. The so what analysis. So I would say that how and where to initiate dialysis are important policy challenge with a huge economic consequence for patients and for society, but also health consequences. It will determine the whole journey, renal journey of the patients. And for that, policymakers, economists, and nephrologists have to find solutions to limit dialysis-related expenditures. And initiating home dialysis for those who can and who want, of course, may represent the most cost-effective strategy if, of course, there is a regulation of the market price for all these consumables. Investing in pre- and stage kidney disease educations has a range of potential payoff, but we need to provide unbiased pre- and stage kidney education by the skilled medical staff, which is not the case currently. We need to integrate more and more conservative kidney care managements in the options for the frailest one. We need research to document the root of the problem with an emphasis on the role of cultures and target priorities intervention, what I'm currently doing. And we need also a cost-benefit analysis of implementing, elaborating, and making more structured PDA programs, pre-dialysis education programs. So, voilà, that's my slide.
So, thank you very much. We already asked a number of questions. There might be additional one, and perhaps that another one if he's still on.
I had to leave like 3 minutes ago.
Yeah.
Okay, but perhaps my comment is that what you beautifully discussed is really relevant to many disease processes. Yeah. And I think it's very timely at the time where to define the right treatment for the right patient at the right time. People think that algorithm AI can do it. And what you just demonstrated is that also we can dream that AI can do the patient education. There is some doubt there. But I think that you add this patient education dimension, which is so critical in medicine in general. That would be my comment. Further questions?
First of all, congratulations. It was very nice, very exciting. One comment, and I fully agree with what you're saying, we should go for home delivery. Of course, as you say, right now there is a big obstacle, which is this price of consumables, and the fact that on the other hand, since consumables are much cheaper in hospital, it is profitable to keep these things in hospital. And so if you don't manage to change the price of consumable outside, the only thing we will have done, I mean, for patients it's better and so on, so that's great. but it's basically taking away profit from hospital and give it to this company Baxter. So in that sense, I think it's from a financial point of view, it's bad for social security, because at some level, hospitals will need to be compensated, or they will need to reduce quality of care and so on. So is it possible, for example, to say, look, let's have home delivery, but still with some involvement of the hospital, who can have access to the consumables at a much lower price, and therefore be rewarded for that in a sense, so that you short circuit Baxter, which, by the way, I don't know who their shareholders are, but not the Belgian government or the Belgian citizen. And you somehow kill two birds with one stone. So you avoid the financial problem for hospitals, and you go indeed towards something which is better for patients and has a higher benefit given the cost. I don't know. I mean,
of it, the manufacturing of PD solutions by the hospitals, you mean? So the process of manufacturing the bags and all the consumable by the hospital itself. In fact, it is done. It's done by some hospital in some country in Italy, and it's there that the PD costs less. And of course, if you produce PD bags or consumable at lower price, the reimbursement could be lower also, because all hospitals need it. It's a wise profit margin. I'm not director of the hospital, but I think it's not necessary to have 50% of benefit margin from the hospital perspective with Incento HD. But on the other hand, when you talk to the medical director, they say, yes, we need dialysis service. We really need dialysis. Otherwise, we are even more in the red. So
I mean, I understand that the incentives are wrong.
Yeah, the incentives
my
are wrong.
point is, in a sense, to reassure the hospitals that somehow they won't lose that money.
Yeah.
Because you won't give it to Baxter.
Yeah.
That was just my idea. How to do it, I don't know.
No, it's really complex, but in fact, they are doing all the process of fluids, PD fluid and home dialysis fluid. PD fluid, I'm pretty sure. They manufacture their own fluids. They are doing that themselves, and it really costs less. It's really cost effective, but you need to engage structures. My point is that I'm afraid that one day it's the pharmaceutical industry that will start their own dialysis center. That's already done in another country, because they have their own products, very expensive product, and they can, if they have their own centers, they can choose to make their own profit margin and to be really be even more cost effective. That's my own concern. Because I'm pretty sure that even it's feasible to manufacture its own consumable for dialysis. It was made at that time, 50 years ago. My nurses told me that the hospital was made its own PD fluid. So it just because Baxter takes the monopoly and impose very high price, but how to get back to this dependent state. We are dependent from the pharmaceutical industry, and I'm worried that we could not reverse the situations. But I'm pretty sure it is feasible within the pharmacy.
You say within hospital they manage not to give the money to Baxter, so it was just my idea. Somebody can do it, so why not try and take advantage of that? Because otherwise you will lose a lot of the financial benefit of moving.
And in developing country, yes, as the import duty taxes are really expensive, they are manufacturing themselves their products, but in fact access to dialysis is really restricted, so that for patients who can pay, they can manufacture their own products. Because import tax are even higher. But it could be one of solutions to control the costs, just logistical aspects and
Three suggestions or comments. The first one is related to this thing is I think the burden of proof is on you. The burden of proof.
The burden of proof.
Convincing the policymakers that they should change the incentive structure in such a way that we move along the lines that you have in mind has to be linked somehow to a cost saving or a cost reallocation. That's one thing. And I don't know if you have the data. There's not a lot of information, but if you do a follow-up research program, that will be something that you may want to do with economists to try to look at the numbers, because it's puzzling not to see numbers. When you Google, you don't find data, actually. And so what you don't measure, you don't do. If you don't measure, you don't do things. It's across. The second thing, and certainly at the macro level, I would certainly look for that. The second thing related to that is that I think the cost-benefit analysis is, as you know, something that I think is useful, but at the same time, a cost-effectiveness analysis.
Cost-effective analysis.
So looking for the purpose of for the healthcare concerns that you have, to look at the more cost, demonstrating that it's more cost-effective to diversify the technology rather than betting on a single technology. Maybe one way of doing that stuff. This is a typical master study that you can do in economics, but it's worth it. People at UCL in London, for instance, would do this sort of issues. And the third thing that I thought was quite interesting is the fact that you were pushing for multidisciplinary approaches. But one of the things that I find interesting in the medical profession is that you all guys are all super specialized. And I thought about my kidney problems from my heart doctor. And so sort of if you do have to have an education program for the doctors, actually you may want to target at least two people. Kidney and heart are super correlated. So you may want to invest also in educating the cardiologist. But as a health patient, the most communication I have is with my GP, my generalist. And if you don't invest in educating your GPs, you may be losing a key part of the management of the fear of the patient. On the patient side, actually, the communication from all of the specialists that you may want to interact with is quite important as well. So it's not just in your field, but it's in related field, because you do have interactions.
Yes, you're right. It's the primary prevention or secondary prevention. Of course, it's the kind of model of quaternary prevention, to educate people who are reaching an incurable stage of disease. But it's you can see that you can still have some impact in terms of delaying progression of dialysis, proposing chronic conservative cares, or leaving kidney donations or home dialysis to keep them more autonomous and flexible. So, of course, early you act as an actors of preventions, and by primary care prevention is really important. They really need to reinforce the.
But that's why the scope of your education program has to be wide enough to be able to include those people who are key players in convincing the patients.
If I may comment, I think that your remark about the GP is critical. The point is that to find a GP who has the time to do this nowadays, it's just a nightmare. If you discuss with people, trying to get an appointment with their GP and discussing the time the GP is spending to discuss diagnosis and treatment, that's a real issue.
I agree with you. But the thing is that it has implications for the way you organize education. Since you know that these people have a time constraint, the way you the way the nephrologist will communicate with them has to be time saving one way or another. But it would be a pity, not as a patient, not to be able to ask my GP, what do you think about this? Because I will do it.
No, you're right, but I think that at the same time, discussing with the policymakers should be that they should.
I'm discussing with the policymakers regarding some dialysis.
And they should realize the importance of this dialogue that you just referred to.
And so yes, the primary care is really important. That's really nice, and we are trying to keep contact with them with seminars and conferences. In fact, multidisciplinary care, holistic approach is very nice, and I think it's like a dream. But is it affordable with our healthcare system? I don't know. I just present the ideal positions I would like to practice in my daily clinical practice, but of course it's not always feasible because I don't have always the time and the motivations to do that.
But the way you organize education may save you time.
Of course, because it's for everything. If you are prepare things better, it's like you do a receipt. If you prepare well a receipt, it will go smoothly afterwards.
And certainly with technology now, because people will, I mean, once you talk to your doctor, many people will Google and see whatever they say. And so if specialists have been able to produce something which is reader friendly or user friendly or visually friendly, it will have an impact and help you, help guide them.
Of course. Yeah, it's of course broader than CKD. Yeah. Yeah.
I see that Naomi is, but I think that we come to the end of the seminar. So really, thank you very much. I think that it was really great, and I really hope that your research project will progress as it should, and perhaps it will have concrete and practical implications, and that indeed policymakers will pay to that.
So.
Now, I would really urge you to continue the discussion with Antonio, because I understood that he could provide you with some keys and tools to indeed provide the numbers that are currently lacking.
Yeah.
Thank you so much.
Thank you.
Thank you.